Good morning, everybody. This is my great pleasure to be here today with you. This is my first time in India, come from Spain, and I must say that I'm impressed with your country and with the quality of the meeting. So, first of all, I will try to give you an idea where we are regarding biology in rotator cuff repairs. Why is it a problem? It is a problem because regardless who is doing the surgery or who is the patient, we have around 2 out of 10 patients who do not heal after a rotator cuff repair. And why does that happen? Well, there are biological factors that we cannot really change much. We know that the older the patient, the larger the tear, and the poorer the quality of the muscle, the result is worse. And then there are some technical factors that we can influence and that were discussed in the previous session. Regarding the technique that we use, we know that biomechanically, if we double row or bridge the repair, it seems to be better healing, but that does not translate into a better clinical outcome so far. We know that early repairs are better than late repairs, and we all know that anti-inflammatories are not a good idea after repairs. So the key understanding in rotator cuff pathology is that the tendon tears because it is determined from the very beginning to tear. There is a biological and genetical factor that we cannot change, but we should aim to modify. Because the quality of the tendon is always poor. Any biopsy that is taken from torn calves show that the quality of the tendon is not good. And that is not because it's traumatic origin, but it is because there is intrinsic problems within the tendon. So what can we do easily in the biology field to improve the healing of the tendon? Well, we should avoid anti-inflammatory medications or corticoids, that we know that. We should control our diabetes, we also know that. And we should tell our patients not to smoke. All those 4 things have proved to be effective in improving the quality of the repair. But in the armamentum of the more advanced biology, what have we done and what have we been able to prove works? Well, there are 4 fields of research. One is the use of growth factors. The second one is the use of matrix and scaffolds. Third one is gene therapy. And the fourth one is the cellular therapy. I have some experience in 2 of them, and that's the experience I'm going to show you in PRP and stem cells. What's PRP? PRP is something coming out from the plattles, and in vitro, when you add PRP to a healing tissue, it shows some improvement. So in vitro, we can say that PRP is beneficial for soft tissue collagen repair. However, the problem is that PRP is so different one from each other, according to how many plattles you have, how they activate, and the amount of blood, of white blood cells that are in the preparation. So we can conclude today that there are no 2 single PRPs that are the same. And then there is another PRP that adds fibrin. Fibrin serves as a very good vehicle for PRP adding into the repair. But the problem is that even though we thought that PRP seemed to be a very good idea when used with fibrin, some of the most recent studies have shown that adding fibrin to the PRP concentrate is not really very helpful. So Does it work, PRP, in other indications? Well, the only quite acceptable evidence on PRP working in tendon repair is in epicondylitis, which is not really a repair, but a tendinosis, and is very weak in Achilles tendinopathy. But what about in the shoulder? Well, the very beginning studies were 10 years ago. They did not show great benefit. And through the last decade, there have been attempts to prove that PRP was better than nothing in rotator cuff repair. Well, all these studies showed very, very weak evidence of PRP working. We did a study in those tears that were more problematic, which were massive calf tears, and we randomized a group of patients with full repairs of massive tears with and without PRP, and what we found was that there was not any difference at all. So, well, does it work? Maybe we were wrong, and we were adding very little, so we tended to add more. And there are studies showing that if you add PRP twice at the time of the operation and then in the clinic, doesn't work either. So after reviewing more than 3,000 patients treated with PRP, different sizes, different repairs, one can conclude that the PRP does not work in improving the healing of rotator cuff tears. You may say that if you double row, if you add something, add something, but that's all hypothetical work. So at the present, PRP has not proved any improvement in rotator cuff repair. What about stem cells? We have available adult stem cells, both from the bone marrow and from fat. We have some experience with adipose-derived mesenchymal stem cells. They are genetically immunoprivileged, and they are very easy to get because you remove fat of patients, and patients loved to be removed fat. So fat from liposuction can be used, or from of your face. What about bone marrow? 10 years ago, they were tried in a rat model. They didn't work. Adipose-derived stem cells are very easy to get, and they have proved to be effective in different pathologies because they reduce inflammation. They have been used in coloproctology with great success. So we thought it was a good idea, so we developed a model of calf tear in the rat, and we added adipose stem cells, and what we found was it didn't work at all, not biomechanically, no histologically. They only gave a little bit of anti-inflammatory effect. So we thought maybe is that we are not delivering the cells properly, so we decided to add a cellulose scaffold to the transfer to be sure that the cells would be there. What we found is that the stem cells with the scaffold did not work either, not biomechanically, not histologically. So we kept going, and we tried adding PRP together with the stem cells. And what we found was that combining the both of two, there was some improvement, both biomechanically, early and late, and the histology. So it seems that combining the stem cells and the growth factors is a better idea than using either of them alone. So what about in humans? Well, stem cells in humans have been used with very little success so far. This is a recent paper with adipose-derived stem cells with a slight increase in healing rate. This is a paper with bone marrow, which is a great success from my standpoint of view. No more comments on that. What about the future? Well, we think that we know nothing, basically. We are in the very beginning of this. And probably the way to go is a combination of things, what has been denominated the secretome. which combines growth factors of different pathways. So if you combine different things, stem cells, growth factors, and we get to know the amount of cells and growth factors that are needed for improvement, that would be an improvement in the healing rate of these problems. Obviously, genetic engineer is something that will always be a way to go, because if we can modify the genetic predisposition to develop this injury, we will be winners. Thank you very much.